Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Eugene Chan. He's a healthcare executive. Today's KevinMD article is Diversified Treatments Are Needed to Fight the Increasing Threat of Liver Cancer. Eugene, welcome back to the show.
Thank you so much, Kevin. Great to be back.
So for those who didn't listen to your first episode together, just briefly share your story and journey.
So I'm a physician and I'm basically also a healthcare executive. So I am one of the co-founders of a biotech company called Apro, which is based here in the Boston area. And we basically develop monoclonal antibody as well as bispecific antibody approaches to treating cancer.
All right. So today we're going to specifically talk about liver cancer. So before talking about your treatment approach, just give us the context and the scope of the issue of liver cancer today.
So liver cancer is an area where there's been increasing sort of cases that have been happening over basically the past, several decades. Part of this is actually based on hepatitis in areas outside of the U.S. And then even within the U.S., just like colon cancer, there's sort of an increasing younger as well as more individuals who have liver cancer. And that becomes concerning because now there needs to be newer approaches to be able to treat liver cancer so that basically patients can get the benefits of the most modern medicines.
All right. So tell us some of the risk factors that one can have to develop liver cancer.
So smoking has always been one of the big ones. Smoking, basically alcoholic cirrhosis is the other one. So these are sort of lifestyle factors that you control. But then there's also sort of virus infections like hepatitis, including things like, hepatitis B and C. In the case of Hep B, if you're not vaccinated to hepatitis B, which here in the U.S. you are, but outside the U.S. it's less common, then basically you could be at a much higher risk for getting liver cancer. And so some of these things, at least lifestyle factors, you can definitely control it. So basically you can quit smoking and quit drinking or, do it in moderation, and you can decrease your risks of sort of those items. And then even in the case of Hep C, basically, there's now new therapies that basically allow you to essentially effectively cure Hep C. So those things would also basically decrease your risk of obviously getting liver cancer. But there's also other factors that we don't know about. And so there's probably other viruses that basically impact sort of how our kind of body handles kind of certain immune reactions. And these are all things that are new and will be discovered as we start understanding, similar to colon cancer, why there are increased cases in young people, right? We're going to start understanding some of these factors hopefully soon so that we can basically do, to them sooner.
So if someone gets diagnosed with hepatocellular carcinoma, what are the traditional treatment approaches today?
So the traditional approaches today range. So it depends if it's a sort of a primary or secondary cancer of the liver. So what I mean by that is basically primary is basically that's where the cancer arose, right in the liver. In other cases, it's a metastasis, straight to the liver. So really kind of depends on the sort of the primary tumor site. Right now, there's several different approaches. You have sort of conventional chemotherapy. There's actually small molecules which basically target certain pathways, including the VEGF receptor, which is sort of a great way of doing it. There's also immunotherapy, PD-1 monoclonal antibodies, which have also kind of recently kind of shown up, which have kind of demonstrated a sort of ability to basically prolong life. And then anti-VEGF inhibitors, and also monoclonal antibodies that are being used as well. And then those are sort of in conjunction with sort of the standard approaches, which includes things like surgical resection, right? So, and it really kind of ultimately depends on the specific nature of the liver cancer as well as the primary location of it, and also depends on the stage. So, and right now I think there's a sort of a little bit of a, I think, over the past 5 years, let's call it 5 to 10 years, there's been sort of advances, definitely on the immunotherapy side. So, and even right now in the pipeline, there's approaches like, what we're developing over at Apro, which is now a bispecific approach to treating hepatocellular carcinoma through a GPC3, which is now one of the markers on liver cancer. And then the bispecific approach, essentially the other half of it basically targets CD3, which is basically brings your immune system to life and basically now brings your basically your white blood cells to basically go and fight cancer specifically. And so that's sort of what I see as sort of the new horizon, both that as well as sort of basically some of these cell-based therapies, which are also being explored. The advantage of having a bispecific approach is that essentially you can do an infusion. You don't have to basically take cells out in person. And basically now, it's a much simpler, more scalable approach to being able to treat with more sort of a punch, to the actual treatment. And so that's sort of the horizon of, basically the new therapies that are going to be coming out. And I think there's great promise, in those approaches.
So there's variation in terms of the 5-year survival rate when it comes to liver cancer. Are there any factors that makes hepatocellular carcinoma more prone to one approach versus another?
Yeah. So I think, when we look at it from a sort of a druggability standpoint, I think a lot of this actually tends to be kind of marker driven. So, or the specific, basically clonality, if you want to, speak in scientific terms, of the actual cell types that you're actually looking at. And so for basically, in the case of what we're developing with GPC3, essentially you're looking at high expressors of this particular cell surface marker, which is going to be like vastly higher in the case of certain types of HCC, and not in others, right? And so, it's almost like, I think the most similar to it would be, taking the breast cancer kind of analogy, basically HER2 expressing cancers versus not, right? Or, estrogen receptor positive or progesterone receptor positive kind of types of cancers. In the case of liver cancer, it's the same thing. So basically there's going to be a higher expressed kind of GPC3 type liver cancer versus others. You do have to kind of check it beforehand before you administer therapy. But once you have specific markers, then basically now you have a little bit of a more tailored approach in terms of choosing, which one it's going to basically look for. And it also depends on stage. So basically, if it's more advanced, then you'll be prone to certain therapies will be better than others at certain stages. And so, particularly some of the PD-1 sort of antibodies, generally you'll want to basically engage that a little bit later as opposed to kind of straight off the bat. And then some of this is also used in conjunction with sort of more conventional chemotherapy type approaches where not just one therapy is effective, but now you're targeting more than one pathway to basically get that response that you want.
So just give us a primer for new drug development. Where are we specifically with the bispecific antibody approach in the drug pipeline, and what needs to be done for it to move forward?
So there's been a sort of a now a precedence of bispecific antibodies being able to target effectively. So it's not just for liver cancer, but for other therapies, both on what we're working on over at APRO as well as for other types of cancers. Generally for basically these bispecific approaches, they've been focused on liquid tumors. So basically your leukemias and your lymphomas, things are a little bit more easily, let's call it druggable, right? Because it's more easily accessible to basically a bispecific type antibody approach. Now, the liver, targeting liver is a little bit different because now it's essentially classified as a solid tumor. Even though your liver is very vascular, you still have sort of basically, you still need a sort of penetration of the bispecific antibody into that tumor site in order to get sort of maximal response. Fortunately for the bispecific type approaches, you're actually relying on activation of T cells. So the T cells now will go find and basically squeeze in through the cracks, essentially. That's the way we think about it, between the vascularity and the solid tumor, and then be able to essentially target basically most of the tumor sites in the solid type tumor. So that's sort of like a huge distinction between sort of pharmacodynamics between, let's say, conventional, let's say even a small molecule chemotherapy drugs, where it's actually harder to penetrate, deep inside the tumor. Here in this case, you're kind of relying on a sort of a cell to kind of squeeze through the cracks. They've got special receptors where they, once it's activated, it actually is able to have that kind of homing sort of technique. And right now, you're seeing these bispecific approaches, they're, in, phase 1, phase 2, or pre-IND. And, based on what we know out there, I think now there's at least like 8 sort of approved therapies using this bispecific kind of T cell activation approach. And I think pharmaceutical companies are gravitating towards that because it's just a much easier way of administering essentially cell-based therapy without sort of the hassles of kind of that ex vivo kind of cell modification approach, as we've seen with CAR T therapies.
So assuming everything goes well with clinical trials, how long do you expect it will take before we see a bispecific antibody approach specifically for hepatocellular carcinoma?
So generally, these trials are reasonably long because I think one of the big concerns that the FDA has is sort of safety, right? So
Hmm.
you are activating T cells. T cells do have cytokine release, so you do want to have a reasonable dose escalation, during the phase 1. And so once you get past the phase 1, it becomes a little bit easier because now you're going in there at a reasonable known, 1 or 2 kind of remaining doses. And then at that point, basically, you're, soup to nuts, basically phase 1 to phase 3, probably around a 5-year cycle. So we're seeing some of these things, in the 2-year mark. For ours in particular, we're, probably in the 4 to 5-year mark for ourselves. But the phase 1s tend to be longer. The phase 2s tend to be a little bit shorter. And then the phase 3s, you're kind of back to that kind of, looking at a little bit more lengthy trial, but you're really kind of looking for what kind of mortality benefit does this give? And also, there's also non-inferiority of these particular agents, compared to conventional methods. So, in a lot of cases, you're basically using this drug on people that have failed other therapies, like the VEGF inhibitors or whatever it might be. And then, so it's actually a harder population that you're basically going after. And basically, if you demonstrate efficacy, against these harder to treat patients, that's where sort of the value in these bispecific approaches, because they have different mechanism of action. They basically pack way more punch than some of these other conventional therapies. That's where sort of we anticipate that there is going to be a reasonable mortality benefit to these drugs.
We're talking to Eugene Chan. He's a healthcare executive. Today's KevinMD article is Diversified Treatments Are Needed to Fight the Increasing Threat of Liver Cancer. Eugene, let's end with some of your take-home messages to the KevinMD audience.
So basically, I think what we're looking at is liver cancer is something that is becoming increasingly concerning, in terms of, just the amount and the rate by which it's increasing. And right now we're seeing conventional therapies, basically they're prolonging life, but it's not enough. And so that's where newer therapies like bispecific antibody approaches, T cell engagers are going to become increasingly more important to basically try to bump up that patient benefit, which right now we're seeing sort of these great therapies that are out there, but still a lot more needs to be done. And that's, basically be on the lookout for some of these newer therapies in the future.
Eugene, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Great. Thank you so much, Kevin.